Well, I'm Dr. Jim Rosso, a dermatologist in Las Vegas, Nevada, and the current president of the American Acne and Rosacea Society. And I want to talk to you about a few observations with acne. First of all, I think it's very important that we very easily can get right to thinking about what we're going to do to treat the patient. We can get a very quick idea of what's going on by just looking at what the patient presents with clinically in terms of their acne. But a lot of these patients have been around the block a couple of times or have preconceived notions with acne. So I think it's important to really and sit down, and I like to sit down and actually look at them straight in the eye. Certainly there may be a parent there, but I like to get the connection with the patient themselves and find out what's actually going on with their acne, what's bothering them the most about their acne, what they may have used that they liked or didn't like, what they perceive are the problems that they're having with their acne. Address diet, even if I'm not necessarily sure I'm going to adjust anything. That lets them know that I care about what's going on with them, not just within my mind as the clinician. A couple of other observations. We do know that we have some excellent topical therapies. We have a lot of generic and branded therapies, but two of the newer branded therapies, and they've been around for a while, but the topical clascoterone 1% cream, which is the androgen receptor inhibitor, recommended that it be used twice a day under the brand name of Winleve. We now have data to show that it does not have any negative effect on the epidermal barrier. The formulation does not increase transepidermal water loss or actually cause moisture to be lost from the epidermis. That's very, very important. We have data to show that actually using it on human skin reduces sebum production. That's been shown in a 12-week interim analysis that Joey Drelos completed that study. And also that if you treat males or females or also adolescents or adults. Adolescents are age 12 to 17. Adults are 18 and older. That in both of those groups, if you break that out, there's no statistically significant difference in terms of the efficacy in either of those groups of patients. So that's very, very important. There was some nominal better results in some particular groups, but all the groups did very, very well, relatively equal in terms of the therapeutic response. Another point that I think is valuable is that we now have a triple combination agent. It's a clindamycin adapalene benzoyl peroxide in a single gel applied once a day under the brand name of Cabtrio. And if you look at the actual data from this particular agent, and there's quite a few studies and there's been quite a few posters that have been out there to show what it can actually do. It's the greatest lesion reductions that we've ever seen with similar types of patients in these acne studies at any time point, as early as 2 to 4 weeks and even over the 12-week course of the study, the greatest inflammatory, non-inflammatory lesion reductions, and investigate a global assessment looking at the patient and saying they're clear or almost clear, and the tolerability was extremely favorable. Now, some people ask, what is the clindamycin doing? We actually have pretty good support over the years, and certainly from the studies with this triple combination, that with the clindamycin, along with the benzoyl peroxide and the adapalene, because we do have benzoyl peroxide retinoid formulations, double combinations, and this triple combination actually does better. And if you compare the dyads in the study as compared to the three active ingredients together, the three do substantially better. So having the three together, I guess three is better than two, and that's what the data shows, and the tolerability is very favorable. Now, I want to bring up a point about another article that was recently published in JAMA Dermatology with John Barbieri and one of his colleagues from Boston, and it's about oral isotretinoin. And it actually shows us that patients that have actually achieved during a course of treatment, and these were patients that had received at least 4 months of oral isotretinoin. There were over 19,000 patients that were evaluated in a database, and this actually showed us what we knew already from other studies that were were looked at. And I think it's important to realize that we want to get as much oral isotretinoin into the patient systemically that we can over a course in treatment. It leads to better long-term results, lower recurrence rates. Now, the daily dose, sometimes you have to modify the daily dose due to tolerability, and that's okay. So if you treat longer, as long as you're getting a substantial amount of the drug over time, and the more systemic absorption they're going to get, the better. And we have to remember that conventional isotretinoins, other than the formulations that are specific formulations, like the microencapsulated, where you don't need food at all and substantially more is absorbed. Where with the conventional isotretinoins, which most of our patients are getting a branded generic isotretinoin, there's major differences in the gastrointestinal absorption depending on the amount of fat. And you're talking about substantial amount of fat that's needed to get optimal absorption. So even though you might be thinking that you're giving the patient a cumulative dose, let's say targeting that 120 milligram per kilogram total dose over time, they could be absorbing half of that, that total amount, depending on how much fat they have in their diet. But I think the bottom line is we want to try to get to giving the patient as much as possible. We could modify the dose downward if they're having too much irritation or problems with dryness, or that's a very real issue in the real world. So if they're getting a lower dose per day, you can treat longer. But the more they're getting in, the less likelihood they're going to have recurrence. So this substantiates information that we've known for some time, and I appreciate John and his colleague putting this in the literature because it continues to reinforce the importance of that principle. Signing off for the AARS, and there'll certainly be more to come.